Is it the truth? Is it fair to all concerned? Will it build goodwill and better friendships? Will it be beneficial to all concerned?
Hello, everyone. President Tom, past President Tom. When Tom Gemmell called me 5 or 6 months ago to ask me to come in and explain what was going to change in healthcare based upon the proposed bills that were then before Congress, I said, why don't we just wait a few months, because by then they'll be adopted and I'll know what to talk about. So I guess you won't mind if I just say I have no idea and sit down. Would that be okay? I will say publicly, there are not a lot of things with which I agree with our current president. This is one of them that I do agree with him about. I do think that hopefully by the end of 20 or 25 minutes of conversation, you'll understand that part of the reason that this has been so difficult for a new bill to be adopted is because this is such a complex subject. And I would suggest that if you look at the person right now on your left, and then look at the person on your right, I think it is fair to say that all of you are willing to cut health care costs for those two people. And that is the essence of the problem of the U.S. healthcare change, because we don't want it to impact us or our families in terms of choice, in terms of quality. I mean, we're very fortunate that we live in a part of the country where there is excellent availability of healthcare services. Those of you who are in the healthcare business do not want it to impact price, because that's how you make your living. And so you try to put all of those things together, solve the access problem, try to reduce cost, and it's no surprise that it's been incredibly difficult, whether we're going to talk about what still exists under what we refer to as Obamacare, or under any other Republican proposals that have been put forth that so far have not been able to be adopted. So let's talk a few minutes about why this is such a problem, because it's not simple, and I think it's really important that we understand sort of the good, the bad, and the ugly about our healthcare system. We do have a lot of availability. Those of you who have friends or relatives who live in other countries, particularly countries that have nationalized medicine, will know that they spend a lot less on healthcare, but it doesn't necessarily mean that it's as available or as contemporary or as technological. I will never forget that 20 or more years ago, I was in an exchange program with the National Health Service in England, and I toured a hospital, and the woman who was the director of nurses was on crutches. And this was in June. And I said to her, what happened to you? And she said, I had a skiing accident. And I said, are you going to be okay? And she said, yes, I'm waiting for my turn for surgery. Now, how many people in this room would think that it would still be okay to be on crutches in June from a skiing accident in the winter? We're just not used to that, because we're used to having health care essentially on demand when we need it and without us having great financial responsibility for it. So this is what we're spending right now, which is essentially a little over $3 trillion. And you'll see that it's roughly divided between the government, that is the federal and state government through the Medicare and Medicaid programs, and all of the rest of us in the private sector, a large amount of which is paid for by employers. I think many, many people in this room grew up post-World War II, where we changed from being a society that paid for its own health care to a society that expected it to be an employer benefit, because post-World War II, healthcare was relatively inexpensive. It was a great benefit for employers to be able to provide, and so employers and unions provided it with very wealthy plans without any thinking about where it could escalate going forward in the future. So when you're talking about the cost of healthcare, it's so enormous that anything that we're talking about, whether it's waste or cutting spending or reducing costs, can have a huge impact even with a small percentage. But it also means it's affecting a ton of people, both as users and as providers of care, and so it's very hard to make change. So what about the federal programs in particular? Because you hear a lot about that in the political discussion. And you'll see, I don't know if you can see the small dotted line that shows where we are essentially today in 2017. But look at what's going to happen to major healthcare programs going forward, the federal programs and the state programs, if we stay on the path that we are right now. And a lot of that is simply because of the age of the population, because you might remember Medicare is the program for individuals who are generally over the age of 62 or 65 or 66, depending upon what year you were born. And Medicaid is the program that largely covers individuals who don't have access to care through their employer and don't have the financial ability to pay for it. There are some programs like programs for end-stage renal disease that are also covered under the Medicare program, but it's largely a program for older Americans. So you'll see that today, the combined two federal programs represent not quite 6% of the gross domestic product, but if we go all the way out to 2045, it'll be approaching 10, not quite a doubling. And today, healthcare in general represents about 18% of the gross domestic product, which if you follow that same trend means we're going to be spending more and more on that, which means spending less and less on infrastructure, education, defense, all of the other things that government spends money on. So it's very important that we do figure out how to contain that rate of escalation at a minimum and reduce cost at a maximum. Now, the real puzzle to a lot of people is what happens as a result of all that spending. Because you would think instinctively that if we're spending so much, and we're spending so much in comparison to other countries, we must have the best results in the world. And we just don't. And I think everybody in this room has seen lots of stories over the years that talk about it. So look at some of the, I don't know if you can see the little red dots on this chart, but if you look at life expectancy at birth, the US isn't even at the halfway mark in comparison to other in comparison to other countries, with Switzerland being at the very top and South Africa being at the bottom. But we're not even at the halfway mark in terms of life expectancy at birth. Same with infant mortality, which is even worse on the next line. And some of this arguably has nothing to do with the healthcare system. It has to do with environmental factors. It has to do with lack of prenatal care on the infant mortality side. It has to do with substance abuse during pregnancy. There are a lot of factors that contribute to that level of infant mortality. Nonetheless, if we're going to look at it as a population problem, we have to figure out what solves for that problem that isn't just spending money on the end when children are born who are severely disabled. If you look at the quality of care, this particular study looked at two things, unmanaged asthma and unmanaged diabetes. And on asthma, we are next to the bottom in terms of the measurement of all of these countries. That's certainly not a good indicator, and yet there are a lot of tools out there that help with the management of asthma. But I think you'll see a trend as we talk about this a little bit, which is essentially that we're much better at procedures and treatment. We're very good at technology, which I'm not disagreeing with. We're not as good at prevention, and we're not as good at attention to our own healthcare, which is part of the issue too. I think if you look at some other countries that have really good statistics, people there are more physically fit perhaps, they're more attentive to their own health and their own weight and their own exercise, and a lot of that contributes to the quality of healthcare and life expectancy as well. And then if you look at the quality of acute care at the bottom, safety during childbirth. Now that seems like that would be a no-brainer for us being at the top of the food chain, and yet we're not. Again, we come out near the bottom. And in terms of heart attack mortality, that's the best statistic on this page. We're close to the top, but we're not the top. And I know that some of you who are involved in healthcare or pay attention to it know that physicians and hospitals have paid a lot of attention in the last, I'd say, 5 or more years to the speed with which you get from the hospital ER to actually have a balloon procedure or to have cardiac surgery. Some of it is in pre-hospital care. Do we know enough about what the signs are of heart attack to get people to the hospital fast enough? So this is not meant to depress you that we're living in the wrong place, but it's meant to say that we're spending all this money on one hand, and yet you would think we could point to the most stellar results in the world on the other hand, and we just don't. A couple of other statistics here. The Bloomberg Healthcare Efficiency Index ranks us 50th out of 55 nations when they did a study in 2014 in terms of healthcare efficiency, how we deliver care quickly and effectively for the least cost, and that shouldn't surprise you given that we just looked at the cost. The Commonwealth Fund, which is a private foundation that looks at research on healthcare issues, said that since 2004, so we're talking about nearly 13 years, The United States has either been last or near last on measures related to access. How do we get care? What's the availability of care? Efficiency, which I just talked about, and equity. Do we have equal access or fairly equivalent access? And we're going to talk about both Obamacare and Trumpcare in a minute, but one of the problems that Obamacare tried to solve for was that access problem, because I don't think it would surprise you to know that if you don't have health care coverage, you put off seeking health care. So if you're a young mother or if you're an elderly person with no coverage and you don't feel well, you think, oh, I don't really have the money, I'll just put it off, and then where do you finally end up? The emergency department, the most expensive place in the entire healthcare system, and that's part of what drives our cost up, because we don't have the right level of access for most of the citizens at the bottom. Final study here, the Millikan Institute at George Washington University said the U.S. is 8th in life expectancy behind countries like Australia and France and the United Kingdom, 12th in immunization coverage for 1-year-olds, and I realize that some immunizations themselves come with political arguments about whether they're safe and effective. Nonetheless, some schools have been mandating them. And 6th in the number of physicians per population. And one of the things that I worry about, since I am approaching the Medicare required age at this point, is the physicians that I see who are going to medical school today are far less interested in primary care than they are in specialty care, and in particular procedural care. Some of that is because of the disparate economics in those professions, but if you, I would imagine that many of you have gone to your general practitioner or internist office at some point in the last year or two and seen a physician extender, a nurse practitioner or a physician assistant, because there simply are not enough primary care physicians. I don't think that's necessarily a bad thing, but we also have to make sure that we're creating enough educational opportunities to have those physician extenders be there as well. I saw this cartoon and I thought that I would put this in because I do think that many people sort of agree with this philosophy that the government's relationship to healthcare is not good. And in fact, I think there are a lot of people who fear the most that we are marching toward a single payer system that will be government controlled and delivered. And given the efficiencies and effectiveness of many of the government programs for things like the Postal Service and even the Defense Department in terms of spending per effectiveness, I think people are concerned about whether the private sector is a better deliverer or the government is a better deliverer. Nonetheless, there are people who are extremely concerned that government is the wrong organization to be involved in the delivery and decision-making about healthcare. So let me just spend a few minutes talking about some of the differences between what we currently have under the Affordable Care Act, referred to as Obamacare, and what I'll call Trumpcare, which is an amalgamation of all of the bills that have been basically put forward by various sectors of the Republican Party so far. So you'll remember that the Affordable Care Act was essentially enacted in 2010, so we're coming up on 7 years. And some of its key beneficial provisions were things like the elimination of lifetime restrictions, prohibiting pre-existing conditions from being a barrier for coverage, not letting people get dropped for that reason. You can't get charged more based on your health status. It did have a provision that required coverage of preventive services and immunizations, which I think was a good thing to address some of the points that I just talked about. I think whether they are well utilized is a different story, because including that in your coverage doesn't necessarily mean that as a population we're used to seeking those services and doing them at the appropriate times. It did extend dependent coverage up to age 26, which I think many, many parents viewed as a very good thing, especially since 2010 was not long after the recession of 2008, where many students who were graduating from high school and college were not getting good jobs with health benefits right away. And I think you probably know that in all of the Republican proposals so far, that provision has stayed. But when you think about it, that comes with a cost too, because the more services that we add into something like this, the more cost we have to figure out how we're going to pay for it. The coupling for that, the sort of offset to it in terms of how we were going to pay for it was, number one, it required large employers to provide insurance to their employees or to pay the penalty tax if they did not. Because one of the things that we'll talk about in a few minutes is the most dangerous thing in terms of health care coverage is if you allow all healthy people to opt out and only people who have pre-existing conditions or other issues from birth opt in, because then what does that do to the price? It's a simple mathematical equation. If you've got people who range from consuming zero healthcare services to consuming, let's say, $100,000 a year, which is not a high number, then you have to have a range of those people in order to make the premiums affordable. And if we let everybody who thinks they don't need health care coverage opt out, that makes the premiums absolutely unaffordable for everybody else. One good thing I think that did happen with this, with Obamacare, was it required insurance companies to spend a fairly high amount of the premium that they collected on actually delivering services. There was no requirement before. So now it ranges somewhere between 80 and 85%, depending upon the size of the company, to say, if you collect $1 of premium, you have to spend 85 cents on actually paying for care. You can't spend it on running the company or other kinds of things, which was a good thing toward marching toward efficiency and effectiveness, I think. And as you know, insurance exchanges were created for individuals who wanted to purchase coverage who weren't covered by an employer or who chose to move outside of their employer's coverage. So what were some of the benefits of ACA, I think, as it existed? Number one, I think, was that it took away the specter of pre-existing conditions. And I think even as employers, you should feel good about that, in the sense that I think prior to that, there were people who had pre-existing conditions who actually did not change jobs, even though they may have felt that their current job wasn't the right one for them, or they really wanted to do something else because they felt compelled to be attached to an insurance policy where they had been pre-qualified and had fear about moving to someplace else where their pre-existing condition would lock them out. I think the most important success, if you will, of Obamacare is that it sliced the number of uninsured almost in half. And because the uninsured do get care, I mean, don't kid ourselves to think that the uninsured are not getting care. They're getting care. They're just getting it at the absolute most expensive point, and oftentimes where their disease or injury has progressed to the point where it costs a lot more. So we as taxpayers eventually pay for it. It's not that they're not getting care. And so to encourage people to actually have coverage and enter the system at a time when they can address issues when they're far less expensive, I think is a positive thing. And then it did make a lot of changes with respect to employer coverage, including coverage of children up to 26, as I mentioned, and also had requirements for things like pediatric dental care. So I think there were some positives that many people would agree with in terms of what the Affordable Care Act did. And this chart shows you what happened to the uninsured population since Obamacare was introduced. At one point, it was as high as 17.5% of the population, 45 million people, and after the introduction of Obamacare, it had dropped to 10.3% of the population. I don't think we'll ever get to the point where it's zero, because people have different barriers to entering the system, but nonetheless, it took 20 million people out of the equation of having no ability to see a primary care physician or to address their health care needs at a sooner point. Okay, so now let's compare it a little bit with what I'm labeling Trumpcare, but what I'm saying is sort of an amalgamation of some of the principal points of the 3 or 4 Republican bills that have been introduced so far. One is that the primary one is to replace the Medicaid system. Now that's the system that's partly funded by the state and partly funded by the federal government to care for those who don't have the ability to purchase insurance. It was really set up in 1965 as coverage for low-income individuals. The one thing that I think is sort of an odd factor that I'll bet you don't know is that more than half of Medicaid dollars in every single state are spent on people in nursing homes. And many of it are people who have dissipated their assets to family members so that they could pass on their inheritance and expect the taxpayers to then cover their cost of nursing homes. Now, if politically that's what we want to do, then we should say that's okay, but that's not what Medicaid was set up to do. And yet, more than 50% of the Medicaid dollars are being spent that way. So that could be a tax reform problem that we need to address as well. In Pennsylvania, for example, when I first got into this business, if you will, the state would look back 3 years and say, if you got rid of your assets within 3 years of qualifying for Medicaid, they wouldn't cover you for that 3-year gap. Now it goes back 5 years, but I know there are a lot of people out there who are still doing it and who expect the government to take care of them if they ever need nursing home care. So I think that's an enormous problem. What the Republican bills largely want to do is to shift from Medicaid being a payment sharing system with the states where it covers you for services like Medicare does, instead to a block grant system where they would say, Pennsylvania, here's whatever the number is, $1 billion for you to cover Medicaid, and you figure out how you're going to cover those individuals with that money, which means that we're going to have likely a quite different Medicaid system state to state. And the one thing that worries me about that is people might actually move in order to take advantage of a state that has what appears to be a better system. And I'm not sure that that's a very good result. On the other hand, I do think we have to pay attention to how those dollars are being spent, and I think states should have an active role in the way those dollars are being spent and not just have it be dictated by the federal government. Most of the bills do also permit states to opt out of some of the current requirements of Obamacare for things like pre-existing conditions, and instead say that they should create high-risk pools for those individuals. It leaves in the mandatory requirement for employers to provide insurance, but takes out the penalty if you don't. So I would argue that means it's not really there. If there's no penalty if you don't have to do it and you don't do it, then essentially the mandate is gone. So the concern there is that the offset that I mentioned in terms of where the revenues come from goes away if in fact that mandatory insurance for employers is not there. It does leave in the children's coverage until age 26, and one of the things that all of us should be thinking about too is it allows states to increase premiums depending upon how old you are. The premiums getting higher and higher as you get older, under the theory that you consume more health expenses, which is true as you get older. I'm just not sure that the economics line up in terms of individuals' ability to pay for it. So what are we spending right now in terms of average cost? Right now we spend just over $10,000 per person per year on healthcare costs. And as you see there, although this is not inflation adjusted, in 1960 that number was $146. So inflation or not, that's an enormous increase in healthcare costs in that period of time. Premiums for the individual right now average just over $300 a month, and for family plans just over $800 a month, but they come with fairly high deductibles, with the idea that you should be thinking about some of your healthcare choices, and we're trying to shift people as a society to paying attention to what healthcare costs. I'll bet there are people in this room who have had a surgical procedure or have gone through a medical procedure who have no idea what their healthcare is going to cost in advance. You might look at the explanation of benefits when it comes from your insurer or from Medicare after the fact, but you don't touch it in a really personal sort of way. And part of the problem and part of the reason that I think we spend so much money is we think that because we've invented it, we should do it. We've basically told physicians that if it's available and they don't do it, we might think about suing them for malpractice. And I think by and large, I really believe that Americans think that we are immortal. And so if we just have drugs or devices, we're going to have something that's going to fix whatever our problem is. And there are enormous dollars being spent on the first 4 weeks after babies are born at sometimes 1 pound or 2 pounds, and enormous money being spent at the end of life when somebody is 102 and still having open heart surgery. So I'm not talking about rationing, but I think we need to talk about rational decision making in terms of our personal decision making when we make some of those choices. I mentioned that we're spending more than other countries. Here's a pretty illustrative chart to show that. We are the second box from the right that shows that we're spending this close to $10,000 a year. And most other countries, including Switzerland, which you may remember has the highest average life expectancy, is spending roughly 80% of what we spend, all the way down to Italy, which spends 1/3 of what we spend, and the average is just about $3,600. I mean, I will be the first to say that many of the countries by comparison have nationalized medicine, and it is a quite different system than we're used to, and I personally would find it hard to imagine many people in this room raising their hand to say, yes, let's have nationalized health care and have it paid for by tax dollars, but I do agree that we're spending in a way that's out of control. Now, so that you don't just think I'm like the most oppressive speaker you've ever had, I want to share some information about some of the things that's good about our healthcare system and the amount of money we're spending. So Basically, for every healthcare dollar that we're spending, we're getting a return of between $2.40 and $3 in terms of both deaths avoided, increased longevity, and I would add increased productivity. The one thing that I have to say that I observed when I was in this exchange with the National Health Service was, although they spent less on healthcare, they had way more people who were retired on disability because they needed a new hip and they didn't get it, and so they retired, and now they were on government disability. Whereas we spend $50,000 and give you a new hip and you go back to work. So I think sometimes when we talk about the cost of health care, we are not necessarily putting all the factors together in terms of what it does from an increased productivity standpoint. So I do think we are getting some positive returns. I think we've had tremendous advances in health outcomes in the last 10 or 20 years, particularly in these areas, heart attack and diabetes and stroke and breast cancer. And for any of you who yourselves have experienced health care for any of those reasons or who have had family members who have had them, I think that you will acknowledge that healthcare and its results are quite different in 2017 from an expectation standpoint than they were in even 1997 or 1987 or further back. So we have good results on some sides. Since 1980, our healthcare expenses are up $2,200 per capita, but the death rate is down 16% from those same things. Our life expectancy from birth is up by over 3 years in that relatively short period of time. This is the one that I was just mentioning. Disability rates are down 25% for people over 65. And because longevity is so much longer, many people over 65 are still in the full-time or part-time workforce. So productivity becomes very important. And another important statistic is that 56% fewer days are spent in the hospital, which is good from both a cost standpoint and from a results standpoint, since there is no reason to be in the hospital unless you need to be there. And part of that is technology with the advent of so many things being done outpatient. And part of it is just simply better turnaround in terms of getting you up and on your feet. I'm sure any of you who have had a joint replacement in the last 10 years have spent 2 hours in bed post-surgery before you were up and walking to test your new knee or your new hip, because we've shown that being still is not a good thing. In terms of what we think about healthcare, about a quarter of Americans say healthcare is the most important issue facing the country today, according to a recent CNN poll. And it beat out everything, including the economy and immigration and foreign policy and the president himself. Fewer than 5% named the other issues that you see at the bottom. And I think that probably is because, if you think about it, healthcare is the one thing among all of those things that absolutely impacts each of us, probably on a daily basis, if not ourselves, then a family member. And so it's something that is very top of mind to us in terms of making it accessible and making it affordable. However, the bad news is that we spend 4 cents of every dollar on prevention and public health. And I think if you look at many of the countries that we were looking at early in this presentation, you'll find that those numbers are completely flipped in terms of the attention to prevention and public health. We spend a lot of money on fixing things after they happen rather than trying to address them up front. And that's a place that I think we must go if we're going to really corral some of this healthcare spending. 75% of all healthcare dollars are spent on patients with one or more chronic conditions, many of which can be prevented. So you see a lot of conversations about everything from smoking cessation to obesity control, asthma control, which is one of the things we talked about before, early immunizations. All of those things have a cost to them that is minuscule in comparison to their negative results if we don't address them up front. 2 other obstacles I want to mention to our change going forward, and one is the relationship between age and cost. I think it's not a surprise to anybody in this room that our population is, the older population is growing because we are definitely living longer, and annual costs for the elderly statistically are 4 to 5 times those of people in their early teens, which probably doesn't shock you because most teenagers don't have any medical conditions other than some conditions that arise from birth, like juvenile diabetes. But the older you get, I mean, I always think that we've done so much technologically to prevent people from dying, but we haven't really done a lot to address chronic conditions that cause people to spend a lot of money on drugs and other kinds of services. People who are over 85 consume 3 times as much health care as people who are between 65 and 74, and 2 times as much as people who are between 75 and 84. So you see that pretty rapid escalation. Now, I don't think the answer is to shoot all the people who are over 85. I don't think that's really a good choice. Or to tell them, like some countries have, that if you get to be 85, you can't have any more joint replacements, or you can't have dialysis. I don't think that's where we want to go as a country. But nonetheless, I do think we have to pay attention earlier in terms of prevention and care so that we don't get to that point. Our median age has increased tremendously in the period since 1960, which then, of course, pushes that elderly population forward. The U.S. Census Bureau says that the population age 65 and older is going to be bigger than the population under 18 in 2056. So from a balancing standpoint between the people we just said don't need much, if any, care and the people who need the most care, it's definitely going in the wrong direction in terms of being skewed. Here's what, on a chart-wise, it looks like. So if you see where we are right now, sort of in the middle toward 2020, and I am part of the guilty crew of the baby boomer generation that is such a gigantic generation that has and is turning 65 and will begin to consume healthcare at a much more rapid pace. You'll see that that lines up with the chart that we looked at way early in the presentation that shows Medicare cost really climbing like the top of the hill of a roller coaster, and that just puts the demand even greater. And medical spending, as I just said, increases rapidly with age. So you see the average there, $3,500 a year if you're a teenager or a child, going up to $9,000, which is the average if you're between 45 and 64, and $32,000 a year if you're over 85. So again, something that we definitely have to be paying attention to in terms of appropriate spending and even personal choice. And those of us who are children of parents or grandparents who are facing some of those choices, I think we don't do a very good job, and I've even talked about this before, we don't do a very good job at recognizing that death is inevitable, and sometimes I would argue we spend money in a way that is not even humane or good for the individual, but we spend it because the technology is there and something we need to think about. So in terms of where we're going with cost, in 2017, we're spending 6% of the gross domestic product, particularly from a Medicare standpoint. In 2047, it'll be above 10, but because of these two factors, aging and excess cost growth. One other factor I want to talk about in terms of an obstacle is technology. I mean, we do love our technology, don't we? And if we have invented it, then we should use it. And in many cases, technology does result in better productivity, better health, and in some cases, lower cost, but not always. And in fact, we were watching sports last night, and Rick said to me, "Why are there commercials for prescription drugs?" And I said, because they want you to go to your doctor on the next visit and say, "I don't want the least expensive drug or the one that you think is most effective. I want the purple pill," or whatever the TV ad says, which in many cases is way more expensive, but the drug companies got permission 25 years ago to advertise directly to each of us, and it's been very effective. And drugs are an enormous piece of the cost that we're talking about. Ironically, a lot of this technology is what's keeping us from dying, is what's advancing our longevity. But then when you lay that against the slides we just looked at that said the older you get, the more you spend, that's a real conundrum, isn't it, in terms of how we control the cost if we're essentially living so much longer. A couple of other things I want to mention is adverse selection. I mentioned that a little bit earlier in terms of we have to evolve a system that does not let people who need the care, who need the insurance, opt into it and everybody else opt out, or it will be so unaffordable that we won't be able to cover it at all. We do definitely have a public attitude about something provided by the government not necessarily being what we're looking for, and that may not be true in all cases. We are a country of individuals who thinks we have the right to make individual choices. I mean, how many remember HMOs from the 80s? They bombed miserably, and why? They took away choice. They said if your family doctor doesn't say you need to go to a urologist, you can't go. And Americans, by and large, voted with their feet and said that I'm not going to be in that plan because I get to decide if I need to take the purple pill or go to a urologist. And so I think we are going to have to be more willing to work in terms of a group of providers who are looking out for our best care, even though it may not be the most expensive care. There are definitely special interest groups who are at work here. I mean, we have evolved a big piece of the economy here, and people are doing well economically from it, whether it's drug companies, medical device companies, healthcare providers. People are generally doing well from the healthcare system. And so to all of a sudden say to them, we're going to only let you charge half of what you charge for drugs, or we're not going to let you spend that much money on healthcare for hospitalization, there are enormous lobbies that are working against that. So that's another obstacle that has to be overcome in terms of where we're marching. And then finally, on this chart, do we think healthcare is a privilege or a right? And I don't think we've actually decided that as a country. I think there are a couple of encouraging things that I'd like to leave you with in terms of things that are helping to make positive change in terms of both cost and outcomes. The Centers for Medicare and Medicaid have adopted what they call a triple aim, where they're basically looking at a system that will coordinate and produce better care and healthier people and smarter spending. And some of this has actually come about through information technology. I bet every person in this room is logged on to either a drug company provider or a healthcare provider where you can go in personally and look at all of your lab results and your next doctor visit and what your results were. And it makes us start to be more personally accountable for what's going on in our own lives and the way that we spend care. And so I think that will evolve over time. I also see some really positive things happening from the payment shift going from fee-for-service, basically, I will pay you for what you do kind of medicine, to I will pay you for the outcome that you achieve. So right now, hospitals are not paid by Medicare if there's an unnecessary readmission. If you have a stroke or if you have a hip replacement and you get discharged and come back within the first 30 days, that hospital is not getting paid for your readmission because they're supposed to be coordinating your care in a way that prevents that. And I see that beginning to work so that we are really having some positive results from it. The other thing that's happening with all of these electronic medical records is practically every provider that you go to can see what every other provider did for you and what the results were. And so there's not the same duplication of lab tests and x-rays and other things that you might have seen in the past. I think that's a real positive. I mentioned before the increase in the number of non-physician clinicians. There's an explosion of physician assistants and nurse practitioners that are delivering very high quality care at a lesser cost because they don't have to go to training as long. And in my personal experience, they're incredibly effective in terms of the majority of care and then in terms of deciding when you need to see somebody else. I think that there are incentives currently for patients to engage in good care, whether it's through your employer or otherwise, both in terms of spending and in terms of taking care of yourself. There's been a big debate in the Department of Labor in the last few months about how much you can incentivize employees to participate in wellness programs that I think has finally been decided. And then finally, I know there's been a lot of conversation in the last several years about a lot of healthcare providers consolidating, which is a direction that Medicare has definitely been pushing providers. And I think some of that you will see produce really good efficiencies. It's not just for the sake of creating bigger and better things all the time, but it's for the sake of creating better coordination, not the thing we have been best about with U.S. healthcare. So with that, I will stop and ask if anybody has any questions in our last 5 minutes.